Hi, good afternoon. I am Sam Masterson, and I serve as the CEO and president for MGFA. I am so excited about this part of the program, I have to tell you. This is the award ceremony. Every year at our annual national conference, MGFA does give awards, and it is a special opportunity for us to recognize those individual volunteers and partners who go above and beyond. They are awards selected by the staff who work on the front lines and do interact significantly with these individuals and these partners. And so, on behalf of the team, I just want to say how proud we are to be able to give these awards today. So, with that said, I am going to I'm going to read each award, and then I'm going to talk a little bit about the recipient, and then I will welcome them to say a few words. So our first award is the Volunteer of the Year Award. The Volunteer of the Year Award recognizes an outstanding volunteer for dedicated service and significant contributions to the MG community by serving in multiple capacities. The recipient of this award is a leader among the volunteer community and upholds the MGFA's mission and values while representing high standards and collaboration. This year's recipient of the Volunteer of the Year Award is Pierre Clement. Now let me tell you a little bit about Pierre. He is a volunteer leader for all seasons. His volunteer efforts reach across multiple community networks, to include his role as an MG friend and both a support group leader and walk leader in the Pacific Northwest. He also was just selected to serve on the National MGFA Patient Leadership Advisory Council, which is a national council. Pierre's positive outlook and can-do attitude has been inspiring and contagious. Whether he's mentoring others on how to lead an effective support group, or he's helping his peers learn the Zoom platform to host virtual meetings, which he did a lot of last year, and we really appreciated that. Pierre provides strong commitment and high impact to the MG community. Please join me in welcoming Pierre to receive the Volunteer of the Year Award.
Good afternoon. My name is Pierre Clement, and I am the recipient of the MGFA 2021 Volunteer of the Year Award. Let me take a moment to thank the MGFA staff and team for recognizing me for this award. I would also like to acknowledge the other Pacific Northwest support leaders and coordinators for their efforts. I could not do this all without them. This is truly a team effort. I would also like to thank my caregiver and wife, Phyllis, for walking with me on this journey. She is my rock. People often ask me why I became an MG friend and MG support leader. My answer is simple. When I was first diagnosed with MG in 2015, the Louisville MG support group leader and people within the group took me by the hand in those first dark and scary days to show me there is light at the end of the tunnel. I also believe my faith in God inspires me to help others, providing guidance, a heart, and ears to listen. Thank you again for this honor.
Thank you, Pierre. Our next award is the Ambassador of the Year Award. The Ambassador of the Year Award is given to a volunteer who provides their talents, energy, and dedicated service towards high-impact engagement to promote MG awareness. The recipient of this award demonstrates active leadership to effect positive change and has gone above and beyond the call of duty to address challenges and find solutions for patients in the MG community. The recipient of the Ambassador of the Year Award is Kim Eldridge. Let me share a little bit about Kim now. Kim's dedication to the mission of the MGFA is outstanding. She serves as the chair of the MGFA Advocacy Work Group, and she also is a member of the MGFA Board of Directors. Kim volunteers her time generously to raise awareness for MG and to advocate for the needs of the rare disease community. She engages with fellow advocacy organizations on behalf of the MGFA, leads advocacy calls, and has attended Rare Across America to meet with local government representatives. She represents MGFA with both dignity and credibility. Please join me in welcoming Kim to receive the Ambassador of the Year Award. Kim?
I would like to say thank you so very much for this award. I can't tell you how much it means to me. 10 years ago in October, I will have been diagnosed with myasthenia for 10 years. It was at that point that I reached out to the MGFA because I wanted to do more. I wanted to help educate the community and help advocate for myasthenics everywhere. The MGFA has allowed me to do this, and I'm so grateful for all of the staff from Sam, Dova, Jenna, Mike, and I'm sure I'm forgetting some other folks, but everybody has been so supportive of the work we are trying to do with the advocacy work group. I believe that we are going to make such an impact for myasthenics everywhere. And I'm just so grateful that I'm able to do this work with the MGFA. And I really thank you so much for this award. It is truly an honor.
Thank you, Kim. The next award that we're going to give is called the Emerging Leader Award. The Emerging Leader Award is given to a rising volunteer leader who inspires, energizes, and extends a strong commitment to support MG patients. The recipient of this award has demonstrated outstanding leadership and significant contributions to the MG community. The recipient of the Emerging Leader Award this year is Jessica Milanis. Let me tell you a little bit about Jessica now. She certainly is a wonderful new leader. She serves as an MG friend and helps to connect newly diagnosed patients with available resources, materials, and emotional support. She leads the MGFA Maya support groups and coordinates efforts for young adults. That's what Maya is. It's a young adult program. She helps to connect them, educate them, and to certainly empower them, which she feels is very important. Jessica leads the San Francisco support group as well as the San Francisco MG Walk. She also just co-facilitated an MGFA regional conference earlier this year, which was very impressive. She did an outstanding job. Jessica is an exemplary volunteer at the MGFA, and her dedication to the MG community is demonstrated and most appreciated. Please join me in welcoming Jessica to receive the Emerging Leader Award. Jessica?
Thank you to the MGFA for this award. It's a great honor to be considered, and it truly means a lot to me. I'd like to dedicate this award to my support group, as this would not have been possible without all of you. I'd also like to thank Joy Baird, Sam Gardner, and Douglas Levin. Joy is a Sacramento support group leader and has been so helpful and supportive of me while starting the new group in San Francisco. We've worked closely together during the pandemic, and I look forward to more great events in the future. Sam and Dova were my first points of contact with the MGFA through the MG Walks, and I appreciate both of your continued help and support. Lastly, I'd like to thank the MGFA and the MG community. I met another person with MG for the first time in 2016 through a support group, which was 10 years into my diagnosis. Since then, it has been amazing to see how large the MG community is and to connect it with people that understand what you're going through. I am very thankful for the MGFA, and I'm excited to continue working with all of you in the future. Thank you again for this award.
Thank you, Jessica. And just as Jessica shared that she gets to work with Dova and Sam regularly from our team, I just cannot tell you, this is one of the greatest pleasures of doing this work in nonprofit, is working with volunteers who just give so selflessly of their time and their energy and their talents. So thank you, Jessica. Our next award is the Medical Professional of the Year. This award is given to a medical professional who consistently achieves high standards in the practice of MG medicine and who is a leader and role model by their peers. The recipient of this award exemplifies excellence and dedication towards advancing the field while sharing expertise to educate the medical and patient community alike. The recipient of the Medical Professional of the Year Award is Dr. James Chip Howard. Let me tell you a little bit about Dr. Howard. He's known as Chip to many. He has generously given his time and expertise to the organization, to our programs and our initiatives for many, many years. And when I say many years, I mean decades. He has quite literally partnered with MGFA and been a friend to the organization for over 40 years. He is one of the most well-respected names in the MG space, exemplifying excellence in medicine, and we are so very fortunate to have him on the team. During this past year, during my own transition and beginning my tenure with MGFA, Chip served as a thoughtful mentor and friend, always accessible and available to me. His work in the field and his desire and passion to foster partnerships that mean something and that have positive outcomes is second to none. I am proud to recognize Dr. Howard for his commitment, dedication, and contributions to the MG community. Please join me in welcoming Dr. James Chip Howard to receive the Medical Professional of the Year Award.
Thank you, Sam, and thank you to the entire foundation for this honor. I'm truly honored and I'm very humbled. There's an old African proverb that says it takes a village to raise a child. And I think it takes a huge worldwide community to get this disease under control and get it out of our lives. MGFA has been a phenomenal partner over the decades that I have associated with it, first as a resident, when I first started going to the meetings with my mentor, T.R. Johns. And it has become the backbone of education for the myasthenic community. We need to energize not only the foundation, our patients, our study coordinators, our research teams, as well as industry around the world. And I believe we can do that in the years to come. So again, my deepest thanks. I'm very humbled.
Thank you, Dr. Howard. And I'm not surprised that he was humbled. He's always a humble partner. Just appreciate him so much. The next award is the Outstanding Service Award, and I am so pleased to give this award. The Outstanding Service Award is given to committed board members whose service and contributions have been integral to the organization's growth and achievements. Recipients of this award have completed long-standing service on the MGFA Board of Directors and are recognized in their final year of service. Denise Rossi from our Board of Directors is in her final term and is receiving the Outstanding Service Award. Let me share a little bit about Denise with you. Denise has served on the board since 2012, and during this time has been a steadfast supporter and dedicated volunteer leader for the organization. Denise has served various roles as a board member, including serving on the executive committee as both our treasurer and our secretary. She's also served as the national chair of our MG Walk program. She has built many, many relationships over the years with volunteers throughout the organization, and she is known to be a trusted friend to all. On behalf of the board of directors, the staff, and our collective community, I want to thank Denise for her service over the years, for her dedication and loyalty, and for always leading with heart. Please join me in welcoming Denise Rossi.
Thank you, Sam. I am honored and grateful to have been a part of the MGFA community and to receive your recognition today. I especially want to thank those of you who live with MG every day and show up with your passion and enthusiasm. You have inspired me over and over. MGFA has changed tremendously over the past 9 years, and I'm proud to think that I have been part of making that change happen. I am grateful to have shared this journey with my fellow board members, the executive committee, or former chairpersons. They are an amazing group of committed volunteers. And finally, on a personal note, I want to thank my mom, who taught me the value, the importance of service and community. And we had the best time ever in Savannah at an MGFA board meeting. Thank you. Thank you, Sam. Thank you, Nancy. Thank you all.
Thank you, Denise. You really can't say enough about the time and energy and leadership that board members give. And some board members may come and complete a term, and others may stay for years. And it's really quite a remarkable thing. It's one of the greatest pleasures I know of personally of the work that I do. I get to work with the board of directors very closely. And I just really want to send another very heartfelt, deep thank you to Denise for her years of service and for all that she's done. And it is so greatly appreciated. And you just can't put a value on something like that. So our next award is the Corporate Partner of the Year Award. And I'm just trying to get it to go up on the screen so you can see it. I'm sorry. I don't know, the slide has disappeared from the screen. Can we get some tech help so we can get that award back up? I'm sorry. I'm trying to get the award back up. Well, I'm telling that I'm hearing that you can see it. I cannot see it, but I can do this by memory. Oh, did somebody just come on? Can you help get the slide up?
Hey, Sam. Yes, the slide is in view for our attendees.
I can't see it. I need to be able to see it to read it.
Just a moment.
Thank you. I apologize for the delay, everyone. I'm sorry, Jordan, are you there?
Hello. Yes, I'm here. Slide is in view. Hi.
I can't see it, so
no
I
worries.
can't read it.
I'll talk you right through it. Just underneath the video window now, click on the slides icon.
Yep.
Small slides icon, and it should bring the slides back into view.
Yeah, they've been there the whole time. I am clicking on them and nothing's coming up. I'm double clicking on them, right? And it should go up to the top, the full screen.
Stand by just a moment. I'm going to try to advance and retract. Here we go.
Okay. I can't see them, so I can't read them. So I think in the interest of time, I'll just speak to them.
Sam, you may need to refresh your browser, or we can read the content of the slide for you either way.
Ah, it worked this time. Okay.
Terrific.
Thank you. All right. I sincerely apologize about that delay. The slide just disappeared for me and I couldn't see it. So I want to get back to the Corporate Partner of the Year. And let me tell you a little bit about what this award is, and then I'll share a little information on the recipient this year. So the Corporate Partner of the Year award is given to a corporation that leverages its resources and expertise to accelerate positive impact and improve the health and well-being of patients in the MG community. The recipient of this award has demonstrated strong collaboration and synergistic alignment to support MGFA strategic goals. The Corporate Partner of the Year this year is UCB Pharmaceuticals. And I'm so thrilled to give this award to UCB. We're currently in the midst of working with them on multiple projects, but let me tell you a little bit about UCB. Our partnership with UCB was built on a strong foundation of open communication, trust, and synergistic vision to achieve success. Our collaboration is focused on shared values, strategic alignment, innovative ideas, and a true commitment to drive impact, which is something that we talk about all the time, is driving impact. And is it the right thing for the community? We are inspired by our friends at UCB and appreciate their support of the MGFA and MG community. Please join me in welcoming our friends from UCB to receive the Corporate Partner of the Year Award.
Thank you. Thank you, Sam. Just want to say thank you on behalf of the whole UCB team. My name is Matt Haritsunian. I'm the head of U.S. advocacy here at the company. Just want to, again, say thanks to Sam, to Wendy, to Dova, to Mike, to Jenna. We work with such a fantastic team at MGFA, and I know on behalf of our entire team, we can't wait to meet you in person someday, which hopefully is sooner rather than later, because we've never actually met. And also thanks to every patient, every caregiver, every loved one who shared their story, their journey of living with MG, their ups, their downs. You are the reason that we do what we do at UCB. We try to put patients at the heart of everything that we do, and this honor is an incredible testament to that work. We look forward to continuing to seek solutions for patients living with MG, and to listening and to learning from, and most importantly, to showing up with you all at MGFA every day. On behalf of UCB, thank you again. Hope to see you all soon.
Thank you, Matt. And I would definitely say, as far as UCB as a partner, they definitely do a lot of listening, and they're very in tune with what's important to the community, and they certainly show up. So that all resonated with me, what Matt said. So very, very proud to give them the Corporate Partner of the Year Award. Okay. Our next award is the Impact Award. This award recognizes a volunteer who has changed the trajectory of the MGFA. The recipient of this award has made an extraordinary impact on the organization through exceptional leadership, collaboration, innovation, and dedication to the organization. The recipient of the Impact Award is Brian Gladden. I'd like to share a little bit about Brian with you all. The Impact Award is actually a new award being given this year. The recipient of this award, Brian, serves as the vice chair of the MGFA Board of Directors. He also is a member of the board's Executive Committee, Finance Committee, and Governance and Nominating Committee. He is a leader through and through, and he takes his role as a leader for the organization to the greatest degree. Brian has been instrumental in designing the new MGFA strategic plan, spending the last year and a half serving as the volunteer leader for the strategic planning process. And he continues to work closely with the MGFA staff on the operational plan. He lends his professional expertise and knowledge so willingly and with both a thoughtful and methodical approach, which is so greatly appreciated. There is no doubt that Brian has quite literally helped to frame the future of the MGFA. Please join me in welcoming Brian to receive the Impact Award.
Thanks, Sam, for this tremendous honor. I'm very proud to be part of the MGFA family and to work with a fantastic team of volunteers and staff in helping to drive our mission to create a world without MG. The work that we've collectively done over the past 2 years has been nothing short of amazing, and I'm glad to have played a small role in moving MGFA forward. Our new strategic plan is based on feedback from all of you, as we surveyed and interviewed many of you to set the priorities for the future. I am so excited to work with the board of directors, the MGFA staff, and our volunteers to help put this strategic plan in motion, to help us drive more resources to the areas that matter the most to our patients, caregivers, and clinicians. Thanks again for the great recognition, and I'm so glad to be a part of the Myasthenia Gravis Foundation of America.
Thank you, Brian. Our next and final award is a very special award. It is a new award this year, and it is the Ellsworth Award. The Ellsworth Award is named for the founders of MGFA. This award recognizes an individual who has rendered distinguished service to the MGFA over many years, no less than 10 years. The recipient of this award has demonstrated long-time commitment, stellar leadership, and passionate dedication to the MGFA and the MG community. The recipient of the Ellsworth Award is Mark Kalish, and I am very honored to share a bit about Mark. So as I mentioned, the award is new this year, and on behalf of the team, we are so proud to give this inaugural award to Mark Kalish. Mark currently serves as a chair emeritus for the MGFA Board of Directors, but he has worn many hats over the years. He has been a steadfast supporter of the organization for decades, first joining the board in 1991. Serving in roles from chair to vice chair to serving on the finance committee, Mark has been present for every major milestone in the history of the organization, and he's been an integral part of the involvement of MGFA, which is why it's extra special to give this first award to Mark that is named after our founders. Mark is a retired attorney who now serves as a mediator and arbitrator. He's known for his direct delivery and candid conversation, which I appreciate very, very much. Mark is that friend that you can go to that will always tell you the way it is. He'll keep you honest, and you know that he'll have your best interest at hand. I have been told that MGFA simply would not exist if it were not for Mark Kalish. That's a powerful statement. Mark's contributions are indelible, and we will forever be grateful to Mark for his presence, for his foresight, and his contributions over the years, which have not only affected MGFA as an organization, but the MG community overall. Please join me in welcoming Mark Kalish.
Thank you, Sam. Thank you to the staff of the MGFA. I am joined today, I don't know if you see them on screen. There we go. My granddaughter, Gabriella, and my wife, Jenny, who have been my COVID partners in isolation over the last year. Jenny has myasthenia and has had it since she was about 9 years old. Although when we met 52 years ago, she was in remission. She came out of remission in about 1985 and contacted the local chapter of what was then the chapter-driven MGFA for information on what had gone on in the 15, 20 years or so since she had gone into remission. And they asked her if she would be willing to help. Now, Jenny, besides the MD, was teaching at the time, and so she didn't feel like she had the energy or the time, so she generously volunteered my services to serve on the chapter board, which eventually led to me becoming a member of the MG National Board, and as Sam said, in 1991. And a slight digression, about 48 years ago, when I was in the Air Force, I received an award, and Jenny had heard another award recipient in accepting his award thank his wife for her contribution. And so when my name was called, she said, remember to thank me for my contributions to you receiving this award. And thinking I was cute, which I later that evening found out I was not being, I stood up and I said, thank you for the award. My wife wanted me to tell you that I owe this one to her. But today I can honestly say, without prompting, that this award I share with my wife, Jenny, my wife of 51 years. And I will tell you all that I have gotten much more out of my service to MGFA than I have given. And I am very proud of what the organization has become. With that said, I'm not sure that the staff made the right decision, because when I joined the National Board in 1991, I was in a group of young Turks, and we worked together to try to change the MGFA. One of those young Turks, who's not so young anymore, Marshall Lorimer. And I'm not convinced that Marcia doesn't at least share in the award. And if I have any say, I'd like to nominate her for next year's Ellsworth Award. But thank you all, and be well, be healthy, and let's find a cure for this disease.
Thank you, Mark. And hello to the rest of the family. And very congratulations on the 50 plus years together. That's amazing. I do want to congratulate all of our award recipients, and I certainly want to thank them. As I had shared before, it's just a real honor to be able to give these awards each year at the conference. And I want to thank the staff, because there was a tremendous amount of thoughtful consideration given to the award recipients. And I just can't say enough about all of that thoughtful consideration. And these particular volunteers and partners, UCB, who were the recipients, for all of their time and energy and dedication and loyalty and support and participation, being active participants in and day out. You can't put a value on that. And I just want to thank them all from the bottom of our heart. So thank you. That's it for the award ceremony. Thank you so much.
Thank you, Sam. I would like to introduce Dr. Shalani Mahajan, who is going to give our next talk. Dr. Mahajan is a neurologist at Attune Health in Los Angeles. After obtaining her MD degree at the University of Delhi, she completed her residency training in neurology at the University of Southern California. She then completed 2 fellowships in neuromuscular medicine, focusing on neuromuscular pathology at the University of Southern California and on neuroelectrodiagnostics and genetics at the University of California, Los Angeles. Dr. Mahajan received her board certification in both neurology and neuromuscular medicine from the American Board of Psychiatry and Neurology. She is a board certified in clinical neuromuscular pathology by the United Council of Neurological Subspecialties. And she has earned the distinction of being a fellow of the American Academy of Neurology. We are pleased to have you here today, and please go ahead.
Thank you, Dova. Can everybody hear me? Yes, Dova, you can hear me? Dova, can you hear me?
Yes, we can hear you.
Thank you. Perfect. Okay. Thank you for the introduction, Dova, and good afternoon, everyone. Here today, taking the time off your Sunday to participate in this conference. I am going to talk about MG one-on-one, what I need to know as a new patient. I can tell you right off the bat, I have extended family members who have chronic autoimmune diseases, and there are a lot of questions that run through the mind when a new diagnosis is given. And so I'm hoping to delve into a few of them, and then happy to take any questions at the end of the meeting as well. So as Dova said, I am an assistant professor at Cedars-Sinai Medical Center, and my focus is autoimmune neuromuscular diseases, focusing on MG and inflammatory myopathies. So some questions, and I can tell you, I know that there are many questions, but some of the main ones that I think I have come across in my experience from patients is, what is MG? What symptoms should I expect? What are my treatment options? How can I do this? What can I do to make things better? What can make things worse? What am I looking at in terms of prognosis, my lifestyle? This disease specifically affects younger women, and I think the question of pregnancy comes up, being able to carry it, affecting the effect on the fetus itself, and of course in the current pandemic, COVID-19 implications. Although I will probably jump through this, as I know you've had a stellar talk by Dr. Howard this morning, and then of course the other questions being, what is the current research, and where can I get more information? So jumping right into the talk, the first question is, of course, what is MG? Yes, I've had these symptoms and I went to a neurologist and they diagnosed me with myasthenia gravis, but what is it really? So briefly, I'll touch upon that. I'm sure you may have heard about it this morning, and you will likely hear more about it tomorrow and day after. So myasthenia gravis is an autoimmune disease, at least the type we're talking about in this conference is an autoimmune disease that results in muscle weakness. The muscle weakness affects the muscles of the limb, muscles of breathing, as well as muscles of swallowing. And the term itself originates from the Greek and the Latin language, mys meaning muscle, asthenia meaning weakness, and gravis meaning grave. So at a time when it was initially discovered and diagnosed, this was considered to be grave because of the treatment implications, the mortality. We've come a long way from that. And even though it's known as myasthenia gravis, I think it should be personally known as just myasthenia, because there's less to worry about the disease now than it was when the term was coined. It is of three essential types: acquired, neonatal, and congenital, and the one we're going to talk about is acquired, which is an acquired autoimmune disease. It is a very rare disease, as many of you know. The prevalence is about 1 in 5,000. So the acquired autoimmune myasthenia gravis, just briefly focusing on the pathophysiology of it. What happens is that the nerves run from the spinal cord out on, if you can see the picture on your upper right-hand corner, the nerves go out and innervate the muscles, which are the brown fibers there. The junction where the nerve enters the muscle is where the problem area is. And an enlarged focus of that is the bottom diagram that you see. So the yellow nerve terminal is coming down onto the muscle itself. And these little tiny red dots that you see are the acetylcholine neurotransmitter that goes on, docks at these receptors here. And then a nerve transmission occurs and allows for the muscle to contract. What happens in MG is that there are these antibodies. Our own immune system produces these little guys, the antibodies, which come and dock on these receptors and essentially blocks the acetylcholine from docking on the transmitters and blocking that nerve impulse, if you will. We also now understand that because along with this process, there's a secondary inflammatory cascade that occurs, which results in some of the weakness, which is a very important aspect because that pathway is now allowing for extensive research, which I'll briefly talk about later in the talk. So what are these antibodies? And the question, the newly diagnosed patient would ask is, well, what causes MG? Did I do something, to bring it on? And the antibodies are well, first let me clear, the patient did not do anything to bring it on, but the antibodies are produced by a gland called the thymus, which is behind the chest bone, as well as the bone marrow. And the thinking is that the thymus is either enlarged, has an inflammatory focus, or there's a tumor itself in the thymus. And the thymus either does not eliminate the cells that produces the antibodies, or if there's inflammatory focus in there, making more of these T cell focused antibodies. So that's basically the just a touching of the disease, base of the disease. The other question is, well, what symptoms can I expect? So myasthenia gravis, for reasons that we don't understand, affects certain muscle groups. They can be just the eyes or they can be generalized. When symptoms are restricted to the ocular muscles, patients develop either droopy eyelids or they can have double vision because of weakness of the extraocular muscles. Symptoms can be also generalized, and when the disease affects the limb muscles, specifically the upper part of your arms and the upper part of your legs, it can cause difficulty walking, difficulty using your upper arms. Most importantly, it can cause fatigue. Decreased endurance. It also affects the facial muscles and the swallowing muscles, resulting in difficulty swallowing, talking. There's a specific sort of a speech that occurs because of inability to the muscles to fully contract and allow for speech, which is described as a nasal speech in patients with myasthenia gravis. And then also you can have neck weakness. The patients can have what we call a dropped head syndrome. So the other question I'm often asked is, do symptoms differ with each case? And the answer is yes. They can differ with each patient. They can occur in combinations. So patients who have symptoms of the disease that are restricted to the eyes initially, 2/3 of those will develop generalized symptoms, i.e. involvement of the limbs or swallowing or breathing. But 1/3 of these patients do remain ocular, and this has to do with prognostic implications. This has to do with treatment implications. Of the patients who generalized, almost 80% do so within 1 year, and within 2 to 3 years, most of the patients do generalize. So the point being, if your symptoms remain ocular in the first 3 years and you don't develop any symptoms of loss of endurance, weakness, you're likely to remain ocular for the rest of your life. This is based on studies done over the years. The symptoms, like I said, can occur in combinations. You can just have, I've seen patients across with just ocular symptoms and breathing problems, or just breathing and swallowing, which we call bulbar myasthenia gravis, or they can have generalized symptoms in different percentages. The important thing in MG patients, which I'm sure a lot of our patients have experienced, a lot of you attending the meeting today, is that these symptoms fluctuate during the day. For the most part, they're better in the morning, and as the day goes on, you develop fatigue. You would have also noted that when you rest after a certain activity and you resume our activities after that, you're sort of recharged. So that can happen as well. This is very specific to the disease in MG, unlike other neuromuscular inflammatory diseases. Specifically for MG, although we're not sure we understand all of the reasons why, but there are certain triggering factors that can affect patients' symptoms day to day and over seasons. So their heat, infection can make things worse. Post-surgery, there's higher risk of MG. Stress definitely can affect the symptomatology, as well as certain medications, and I'm going to go into that in a minute. So I'm not going to get into the diagnosis of the disease. This is assuming that the patient has been diagnosed by a neurologist, neuromuscular neurologist, and you have a certain spectrum of the disease. So the next question is, well, what are my treatment options? So I'd like to say that the goal of the treatment of MG is to have the person function in their fullest capacity with minimal symptoms and hopefully even in remission. And so we have different drugs that are now available to us. Some of the drugs are symptomatic, like the cholinesterase inhibitors, pyridostigmine, as many of you may be taking. But the crux of the treatment has to be immune. It has to suppress the immune response or modify the immune response to be able to treat the disease per se. And that immune treatment focuses on corticosteroids to start with, typically. But we also have immunoglobulins. We have immunosuppressant medications like mycophenolate, azathioprine, and there are some newer medications as well we're going to talk about in a bit. And then for more severe form of the disease, we have plasmapheresis that is available as well. Not as much used today as it was maybe 20, 30 years ago because of the availability of immunoglobulins, other newer medications, but also a very robust medical management within the ICU, including treatment of infections and respiratory care. And then, of course, thymectomy, which is where the antibodies are produced. And so there are certain guidelines for thymectomy, and I believe you also have a talk on should I get a thymectomy, I think on Tuesday. So I'll touch base on some of the medications. Like I said, symptomatically, we have the cholinesterase inhibitors, specifically the parastigmine. I always tell my patients to keep this medication handy with them. The onset's within about an hour, and it can help you with symptoms lasting. It can help you for about 4 to 6 hours. Like I said, the focus of the treatment should be immune medications, steroids. Prednisone is an excellent drug. The advantage is it's quick acting. It can be given orally, and it's specifically shown to be good for ocular myasthenia gravis. But there are certain side effects as well because of which we cannot give that long term. And that's where the steroid-sparing immunosuppressant medications come in, like mycophenolate, azathioprine, cyclosporin, rituximab, and then there are newer agents like eculizumab. So one of the questions that was asked to me is, well, what can I do to make it quickly better, and how do I keep this long-term away or improved? And so the treatments that induce rapid response, typically used across hospitals, is immunoglobulins, IVIG, which can now be given subcutaneously as well. Plasma exchange, like I said, in more severe forms of MG, like myasthenia crisis, and then the medical management in the ICU of coexisting infections as well as respiratory care. Side effects, I think a question always comes up whenever any medication or new medication is given. Question that will come up is, what are the side effects? What are the complications? What am I risking when I take this medication? With MG medications, those are many, but they can be navigated around. With the cholinesterase inhibitors, typically the side effect is dose related, typically. Muscle twitching, abdominal cramping, excessive sweating, saliva. With corticosteroids, most commonly is mood changes, GI intolerability in terms of having dyspepsia, high blood sugars. In fact, this is one of the side effects that limits our use of corticosteroids in patients with diabetes or who have tendency to high blood sugars. Bone loss, osteopenia, osteoporosis is a long-term complication, again, which limits its long-term use. And then other side effects, problems to be aware about is cataracts and glaucoma. With the immunosuppressants, I think each of the immunosuppressants has a different side effect profile, which would be outside the scope of this talk, but safe to say that increased risk of infections is a risk with all immunosuppressant medications. Bone marrow suppression, which is most often dose related, is of concern. And then, of course, there's the long-term risk of malignancy as well. So those are the things that are to be discussed with any patient whenever a new diagnosis is made. And then the choice of medication has to be made based on their comorbidities, their other medical issues, family histories, etc. And then what are the side effects of IV treatments? With IVIG, typically the immediate side effects are headache, high blood pressure, rash, but there's also a very rare increased risk of thrombosis and aseptic meningitis. Now, I list these, although these sound scary, but these are easily navigated around by giving the medications and the treatments in a judicious manner. Plasmapheresis is done at the hospitals, outpatient centers, dialysis centers, and they can cause hemodynamic instability, and so it's to be done with caution, especially if the patients are older. I'll briefly touch upon thymectomy because I know, like I said, you have a whole talk dedicated on tomorrow. But what is thymectomy? Thymectomy is the surgical removal of the thymus gland right here if it is either enlarged or if a tumor develops within the gland. The nice thing about thymectomy now is that the access to the thymus is through the side is through a robotic assisted or video assisted procedure. The post-op morbidity is tremendously less than it was, let's say 20 years ago, where you would have to open the chest and access the thymus from the front. So this is widely used. Obviously, there's a specific indication for it, and that indication is recommended now is that if you are seropositive, meaning you are testing positive for one of the antibodies that diagnose myasthenia gravis, you do a CT scan of the chest is recommended, and if there's a thymoma that's seen, then you go ahead and proceed with a thymectomy. If you do not see a tumor of the thymus, but you're less than 60 years, and you do have acetylcholine positive disease, if you have generalized symptoms, you proceed towards thymectomy. If you have disabling ocular symptoms, you proceed towards thymectomy. So there are reasonably few number of indications for thymectomy. The time where you would not do a thymectomy is if you're over 60 years. There's no data available for a MuSK antibody related MG, or if your symptoms are not as disabling and possibly restricted just to the ocular muscles. So the other question that I get is, well, what can I do and what should I avoid so I don't make my disease worse? So one of the things that all patients need to be aware of is that heat can make this disease worse in terms of symptoms. So you will feel excessively fatigued, weaker. I tell patients to avoid the heat, to avoid a crisis. Infections can worsen disease as well. So whenever you have any sort of intercurrent infection, UTI, pneumonia, you have to be very aggressive. The treating neurologists along with their primary cares have to be very aggressive about treating the infections, not just for the infection itself, but more importantly, the MG implications. Live vaccines, certain flu vaccines, MMRs should be avoided. They have a higher risk of worsening MG. Perioperative monitoring is very important, especially post-op as the patients are coming out of anesthesia. So I tell my patients that if they were to go into an elective surgical procedure, I should coordinate with the surgeon, the anesthesiologist, so as to make them aware that the patient has myasthenia gravis. There are certain anesthetics that are to be avoided. And so the anesthesiologists today are very aware of what needs to be done in the perioperative period, but that is something that needs to be addressed. Post-delivery, there's a risk of weakening as well, not just because of the fatigue of the delivery, but just that time of the delivery. When patients are being tapered off immune medications, there's a risk of the disease getting worse, and so it is really very important that any tapering of the treatment, either for side effects or for no response, or for having been in remission, that the taper is done very slowly so as not to worsen the disease. And there are certain medications that actually worsen the MG, and these are some commonly used antibiotics. So I always tell my patients to have a list of these medications with them so that if they are in another town or in the ER, they provide the list to the treating physician so as they don't prescribe these medications. Typically, these are the fluoxetine antibiotics, some of the tetracycline antibiotics, beta blockers, magnesium, and these days, they're the newer chemotherapeutic agents that are used for a lot of cancer that have now been shown to be associated with MG. This is, a difficult medication. Just to say no, because these medications are used for cancer therapy, and so just judicious decision making is recommended in coordination with the oncologist, the primary care, as well as the treating neurologist. So the anesthetic agents, some of them, the non-depolarizing agents, need to be avoided, and so the anesthesiologist needs to be informed. Certain calcium channel blockers, Botox, very commonly used, at least in my neck of the woods. We generally recommend that patients with MG do not do avoid Botox because of where the site of action of Botox is at the neuromuscular junction. Of course, the MGFA, tremendous organization, providing resources. So if you have any doubt, go on the AANEM website, MGFA website as well, and you can get a list of those medications. So yes, so the patient was diagnosed, patient was treated, and they're getting better. And then they ask, well, if I notice some worsening, when do I go to the ER? So I tell patients whenever they have fever, infections, or shortness of breath, that's one time. So anytime you're not comfortable with your symptoms at home, pick up the phone and call your treating neurologist, treating primary care physician, and if they're not available, seek medical help at an urgent care or an ER. There's a term that many patients may have heard, myasthenic crisis. It's much less occurring now than it did again 20 years ago. But the term itself refers to severe difficulty breathing or difficulty swallowing, and you're not able to, and you're not comfortable just being by yourself, and your respiratory muscles are so weak that you need assistance in some form. So that's a situation where you definitely need to be in the ER. Another term is cholinergic crisis, which is when patients take excessive amount of pyridostigmine, which is used for symptomatic treatment of MG. I have come across patients taking very many of these tablets, and that in itself can cause a different kind of weakness, which is what we term as a cholinergic crisis. But it has to be distinguished from a myasthenic crisis. So it's not your disease getting worse, but in fact it's not an overdose, but a toxicity of the medication you're taking to treat MG. So a neurologist or an ER physician can differentiate that. Typically, excessive salivation or sweating would be accompanying things like cholinergic crisis. So one of the things that I advise patients is to keep an MG medical bracelet or a wallet card, so that in the event you are by yourself or you're not able to breathe and you have paramedics that reach you or your friends are there with you, they can get help through the card that you have. Briefly dwelling upon myasthenic crisis, again, like I said, very significant difficulty swallowing, speaking, or shortness of breath, often precipitated by infection, childbirth, certain medications, and you are at risk for life-threatening respiratory failure. So you have to seek medical attention. These are robustly treated now by way of IVIG, plasma exchange, as well as IV steroids. And I want to make a distinction that is different from a myasthenic flare. So a flare could be just an exacerbation of symptoms. These are manageable at home. So you could have weakness at home, but your respiratory status may be stable, and that's transient. But when you have life-threatening respiratory difficulty and you're not able to breathe comfortably, then I would always say flare or crisis or anxiety or all of the above, just seek medical attention. It's always better. So the other question that patients want to know is, well, what is my prognosis? What am I looking at in terms of treatment? And I think that's where I wanted to circle back to the what I was mentioning early on in my presentation, is that it is not gravis anymore. It's not grave anymore. We have very many treatments now. We have newer treatments that just got FDA approval. We have many more treatments in the pipeline. And I think that with current treatments, we do tell our patients you have normal lifespan. We aim to have you functioning at your fullest capacity. Obviously, that depends on the job that you're working at. The mortality in a recent Danish study was extremely low. It's 0.43 per million population. So there is morbidity that is associated with the disease in terms of intercurrent infections, or you fall because of the weakness, and more commonly, adverse effects from medications. But those, like I said, are easily navigated around, and the disease is easily managed. Ocular symptoms, again, prognosis. Patients who have only ocular symptoms typically generalize if they do within 3 years. And then the generalized patients, of the patients who develop generalized disease, the disease is typically worse in the first 3 years based on studies that have been done. And as right along with prognosis is, well, how does it affect my life? How does it affect my work? So one of the key factors I think that really affects the disease and compound symptoms is stress and anxiety. So that's one factor. The goal of treatment, like I said, is to be their best and fullest capacity. So exercise and physical activity, where the recommendations are to continue as tolerated. Of course, what you're able to do and what your fitness level will allow you to do will be based on your pre-disease status, your other medical issues, as well as the severity of the disease. So those need to be taken into account. Likewise, for your returning of work, obviously a patient who has a more physically demanding job may not be able to return to its fullest extent, but somebody who has a more sedentary job should be able to return to their job. And then us as treating physicians, we're often able to help patients with modification at their job in whatever form that may be needed. And like I said, stress management and adequate sleep is very important. Joba, am I on time? Okay, so I'll rush through these. Can I exercise with MG? What I recommend patients is, and what is recommended is, as tolerated. You stop when you feel tired. You need to take rest. I recommend patients take short sessions of exercise, not an hour worth session. Obviously, again, I say that with the caveat that it depends on everybody's pre-disease state and ability, and of course their response to treatment. Mild to moderate resistance training is recommended. Yoga or any sort of stretching, whether it's Pilates, helps as well. And like I said, what you can do will depend on your age and fitness level. Any disease, any foods that I should avoid is a question that I often get asked. I tell them to eat a healthy diet. There is no data as yet that an anti-inflammatory diet or a specific gluten-free diet or things like that can make the disease better. So I always tell patients to take a healthy diet as recommended by the American Dietetic Association. Magnesium supplements, though, should be avoided. Magnesium is known to make the disease worse. And so that's something that should be kept in mind. What do I need to monitor while I'm being treated for MG? So like I said before, infections, you always need to be very vigilant about, especially UTIs and pneumonias. They can be the symptoms can be subtle if you have especially comorbidities such as diabetes. So your treating physicians and you should make a good team to be able to detect these early and treat these early. The disease itself is associated with an increased risk of infections, almost to 39%. Compared with the general population, which has about a 20% risk of infection. The medications that MG patients are on, while you're on those medications, you need to be very strict about monitoring them for blood counts so that you monitor them for bone marrow suppression. And there are some medications that affect the liver, and so the liver functions need to be monitored as well. So I tell my patients, depending on what medications they're on, to have these blood counts done on a regular basis. one of the questions I get asked is, well, are my antibodies level, do they correlate with the disease activity? If the antibody is present or it's a higher level this time around, does that mean my disease is getting worse? And the studies have shown that antibodies do not correlate with disease activity or, for that matter, improvement. Pregnancy is a big issue, and the question that get asked is, can I get pregnant while I'm being treated for MG? And the answer is yes, but you will need to be monitored, especially because some of the drugs used to treat MG have been known to have birth defects and can affect fertility. So pre-pregnancy counseling is a big concept in my treatment and management. I tell patients to have a discussion with their gynecologist if they have one. They need to discuss with me or their treating neurologist when they're planning a family, so that appropriate therapies can be started prior to their starting a family. And more importantly, specifically, some teratogenic medications like methotrexate and mycophenolate can be avoided. The good news is that the disease is stable before pregnancy. Likely you will be able to carry through your pregnancy and your disease will be stable. The medications that are known to be safe and are recommended during the course of the pregnancy are anticholinesterase inhibitors, pyridostigmine, steroids, and if you are getting severely weak or in crisis, IVIG and plasma exchange. Post-pregnancy, for preeclampsia, for high blood pressure, gynecologists routinely give magnesium supplements. In MG patients, those would be contraindicated. The other question that I write following pregnancy is my child going to get MG? Will I pass my MG down to my kids? And so I want to clarify that today's autoimmune acquired MG is not an inherited disease. It's an adult onset disease typically. But you may come across this term called neonatal myasthenia gravis and congenital myasthenia gravis, and they're two distinct terms. The neonatal myasthenia gravis refers to transient symptoms of myasthenia gravis that can occur in your newborn if the mom has myasthenia gravis. And that happens because temporarily the antibodies transfer from the mom to the newborn and through the placenta. But as the baby's immune system starts getting revved up and producing its own antibodies, the mom's antibodies are then flushed away and the baby recovers. Congenital myasthenia gravis is a very different disease. It's a hereditary disease which has a genetic mutation, starts when you're typically when you're much younger, but that's not the acquired autoimmune MG that we're talking about today. COVID-19 implications, I think for the sake of time, I had some couple of slides prepared, but for the sake of time, and I think we have you have a separate talk, of course, by Dr. Howard. We'll jump over it. That it's safe to say that data is being collected in registry, and patients on immunosuppressant therapy are at higher risk, and so you should have those discussions with your neurologist. COVID vaccine, I think Dr. Howard talked about these. And then, so I'm going to talk about the current research. What is the current research? There are a lot of, this is what I'm most excited about is, again, coming back, I want to call it myasthenia, not myasthenia gravis, because we have very many new treatments. There are different pharmaceutical agents being researched based on the inflammatory cascade that we are now understanding that is at play in MG. Stem cell transplants have been proposed, being researched, and of course, how the disease interacts with the immune response of COVID-19 is being studied and data is being collected as well. So these are just some of the drugs that are being studied right now, currently in trials. And then last, of course, is where can I get more information? These are some organizations which can provide more information. Myasthenia Gravis Foundation, of course, has been at the forefront of providing tremendous information up-to-date information for the patients. And there are some books out as well. There's a new book out called Coping with MG that has, I understand, some comments by experts and patient experiences, Center for Communicable Diseases. So you have a lot of resources now literally at our fingertips with our phone. And I think that in this day and age with the treatment available, I'm optimistic, and I tell my patients to be optimistic that with active participation, team approach, modifying your lifestyle, there's no reason that this disease should limit your activities in any way. So on that note, I will thank you for your time and attention, and happy to take any questions.
Thank you, Dr. Mahajan. I do have a few questions that were sent in through our chat.
Sure.
The first one says, if both an MG patient and a non-MG family member are vaccinated, is it safe for the non-MG family member to fly to town for a visit? What extra precautions do you recommend during this visit?
So the non-MG patient is out of town?
Correct.
And they're flying in to visit the MG patient in town. Right. And they're both vaccinated, you said?
Correct.
So that is an interesting question. I get asked all this time. What we understand based on the limited data that we have with COVID vaccines is that in patients who do not have myasthenia gravis, there's a robust antibody response to COVID-19 infection after the vaccine is given in about a month's time. With the MG patients, depending on what immunosuppressants they are on, there should be some level of protection, but it may not be as robust as the non-MG patients. So what I say, and more than that, we don't know the answer as to how safe it might be. So what I tell my patients is, if you are on immunosuppressant medications, whether or not you're vaccinated, until we get more definitive data through registries that are happening, take all to the question, yes, the out-of-town patient can come in and meet with the MG patient, but take all the precautions for now as is being recommended by the CDC, i.e. gloves, masks, social distancing, at least 6 feet for now, until we get more definitive data as to how robust is the protective response of the vaccine to COVID in patients who are immunosuppressed.
Great, thank you. The next question is, could you explain more about the complement sequence and how it affects MG?
Wow, this is a whole talk in and of itself. The complement, I briefly referenced it. It is, like I said, I think we'll have to sort of take this. I'm happy to answer this question separately because it would be a very long answer. It's safe to say that this inflammatory pathway, the recently sort of noted, and this is being researched now because a whole slew of medications is being researched looking at inhibiting some of the complements, the C3, C5, that are implicated now in the pathogenesis of the disease. But I'm happy to respond to the person independently.
Okay, great, thank you. The next question is, should a bone density test be standard procedure before prescribing prednisone to control MG? I suffered 4 spontaneous spinal fractures from prednisone.
The answer, that's a very good question. And yes, the answer to that is yes. So I do get bone density scans pre-steroids, especially in patients who are at risk for osteopenia or osteoporosis. So postmenopausal women, and perimenopausal women, we do get DEXA scans, and I think that DEXA scan is recommended prior to starting steroids.
Great, thank you. So this question is, how do I find a doctor who can help me with my diagnosis?
Well, the Myasthenia Gravis Foundation of America is one information source right there. Your local, I think that's a big source. Your local physicians, primary care internists should be able to, should know the local neurologist who may then refer you to subspecialists such as like myself, and then, get you to the right subspecialty physician.
Great, thank you. And yes, the MGFA website does have partners in care physicians listed by state. So you can look for your state, or you can even look for another state that's close to you, if that's closer than a doctor that you might find on there within your state. Thank you. The next question is, how often do patients have adverse kidney reactions to IVIG?
Extremely rare. I don't know the percentage off the top of my head, but it's extremely rare. One of the things that can affect the kidney function is the degree of sugar in the IVIG preparation, as well as the rate of infusion. So I give IVIG on a very conservative side in terms of rate of infusion. I think that determines the degree of kidney failure, and one has to monitor the kidney function as well. So, but it's extremely low. I have had patients who've had blood clots, but not kidney failure with IVIG. It's extremely rare, but I don't know the exact percentage.
We have another IVIG question. Can IVIG be given again, perhaps another brand, when there's been a reaction of large raised red areas on abdomen, great weakness, peeling of skin on palms of hands, etc.? These first 4 days were great, muscle strength, much decreased fatigue.
The answer is an absolutely yes. Any side effect to IVIG, they can be treated, managed. There are over, I think, 8 or 9 brands of IVIG at least approved in the United States. And the answer to the specific question is yes, you can, and one should try different brands of IVIG to see what may work. And if the IVIG itself is not, the IV formulation is not working, a lot of patients who don't respond well to IVIG do actually good with subcutaneous IG formulation. So there are very many options in patients who may have developed a reaction in their first go.
Thank you. At one point in time, there were 20 plus members of my maternal grandfather's side of the family with autoimmune MG. How often does this happen if it is not genetic?
So I think that what we know about autoimmune diseases is that autoimmune diseases can and do run in families. There is no specific genetic focus that has been identified, at least to my knowledge, to link those. Now, even in MG, there are certain HLA subtypes where there's a predisposition to MG, but to my knowledge, there is no specific genetic focus that one can ascribe to hereditary autoimmune MG. So I think if you have family members, and as many as 20, I think definitely you should, your doctor should be discussing this with a geneticist or an academic institution around there so that they can in fact research into the genetics of this, and we can learn more from your family, I would say.
Great, that sounds great. We're going to take one more question. I know there's a lot of questions that were submitted, and we will try to get to all of them. If we don't, we're going to take one more, but we'll try to get the answers for everyone's questions after the conference and get them out to everybody. This question is, what do you mean by be careful in warm weather? Can I go to the beach, outdoor activities? What temperature should be concerning?
So there's no exact temperature that I can tell you that you should stay below a certain temperature. What I tell patients is definitely go out to the beach. A, obviously have sun protection, but B, dress yourself so that you don't get excessively warm. And anytime, while you're at the beach or at the place where you're relaxing, if you start feeling weaker, fatigued, tired, your eyes start drooping, you need to then come and move to a cooler place. That's the best that I could recommend. There's no hard and fast temperature of 75 degrees or 80 degrees that you need to avoid. The cooler, the more ambient temperature, the better.
Thank you so much, Dr. Mahajan, for your talk. We appreciate you speaking to us today. And for everyone,
thank you to everybody for their time on a Sunday. And thank you, Dova, for organizing this. And Jordan and the entire team. Nancy, Sam, everybody.
Thank you so much. And thanks to everyone for joining the MGFA conference today. We want to give special thanks to all of our speakers and to our sponsors, Alexion, Argenix, Immunovant, Janssen Pharmaceutical Companies of Johnson & Johnson, UCB, Catalyst, CSI Pharmacy, and Solio Health. We certainly hope that all of you will join us again tomorrow. Thank you. Bye-bye.